we are bringing a new area, which is something you know, but probably you will not be knowing in detail. You heard in clinical statistics, or say medical statistics, the p-value and the confidence interval, and we know something about that and how to apply for our fellow research. But these days, beyond that, meta-analysis is taking shape in our literary work as well as in our research work everywhere. And we would like to make you well aware of what is meta-analysis and what are the areas where it could be applied, and is there an international regulation applied to meta-analysis applications, and how to review an article done through meta-analysis. And all these things going to be informed by two veterans in this particular area. And the chief moderator or the presenter of the day is Dr. Rakesh Garg, who is the chief editor of Indian Journal of Anesthesia and is a well-known academician in India. He's an excellent personality and a friend in need. And he's going to talk to you on all matters of statistics. And you know how the Indian Journal of Anesthesia has come up in the last 2 years. The impressed factor which the journal carries now is a real eye-opener to his hard work in the area. And today, Garg is joined by another friend of ours, Thrivikrama, Tantry, and Thrivikrama, and a good old friend of mine, probably a student also sometime back. And well, he is going to be helping us and God in detailing the topic further and further. So before we open the topic of discussion today, I may like to inform you certain matters regarding the ICA which are good for you. We thought of starting something new again, because in the medical side, or say in anesthesia, or say in India, we were the pioneers to start the webinars during the high COVID times. And we are in the 5th year of our webinars. And once we started the webinar, well, people from everywhere started following us. They have taken the cue and they have doing it very well these days. Like that, we are now opening another area called the Indian College of Anesthesiology Olympiad. This Olympiad is something which we are thinking of for the last 1 year. This is a particular test, an objective type examination for the postgraduates. And we are inviting all the postgraduates of India to come for this one. This is to give you a preparatory class on how to appear for national and international online examinations. Well, you know, Medical Council of India, National Medical Commission, as well as the National Board of Examinations, are doing the online examinations these days. And they are also having the quiz through the online examination. And some of the questions are coming that way. And you know the fellowship examinations, states, or say Europe, or European Diploma of Anesthesia, or critical care, everywhere, most of the time, they are engaging the students to know their knowledge and expertise within a short period by conducting online examination. So here we are giving you a chance, or rather an attempt, to make you used to these sort of examinations then. And we will be doing the first Olympiad in anesthesia, or say examination, a preparatory examination in anesthesia on 6th of April 2025. And we are limiting the number of seats to 300 to start with. And we are requesting people to register for the particular course and the examinations. This will be a 2-hour long examination. This is a proctored examination. And the questions are going to be done through Indian faculty. And the questions are all sorts. Yes, no, probable best answer, assertions, negativism, all these things going to factor in the examinations. And this in short will be almost the same like a UK examination or an American examination or a European or Australian examination. And we are attaching some good price also to make you interested to come out to this particular examination. And the first prize is going to be 50,000 rupees, and the second is 25,000, and the third is 10,000 rupees. This will be the price what we're going to give. And this is artificial intelligence generated as well as human proctored examination. And we wish you all to register. And now we are allowing all the postgraduates. We are not at all keeping first or second or third year differentiation. Anybody who's interested, they can come over and get used to the examination. And before the examination starts, we will be giving you some lectures on how to appear for the examination or how to become prepared for the examination, as well as we're going to give you some mock examinations also. And the fees for registration till 5th of March is an early bird offer of 1,000 rupees. And 5th of March till the examination, 24 hours early to the examination, we're going to charge 2,500 rupees. We are limiting our crowd to 300. Probably we may extend by another 15 or 20, not beyond that. So please prepare for the examination, and you'll be getting more information through the college website, and kindly register at the earliest, because this examination, I am sure, is going to be sponsored by everybody, as well as is going to run fast. And welcome you all. The first ever attempt of Indian Anaesthesiology crowd to do an online international examination, which is now limited to the national postgraduates. Next. Well, you know about our national conference. We are doing national conference from 2008 onwards. In 2008, the college started. College was registered in 2008. And from 2008, we are every year doing a national conference. During the COVID years, well, we are not able to do it. But this year's ICA Con 2025 is going to be at Jodhpur. Last year's conference, which we have shown the glimpse, which happened at Lucknow. And this year it's going to be at Jodhpur. And I'm sure the way it goes, or say the arrangements being done by the organization, this is going to be a real money worth conference. This is something going to be good, because Dr. Bharat Paliwal and his team members are keeping all the stones straight to make this particular program a memorable. In Jodhpur, an area of tourism, I mean, the farthest part in the Rajasthan, Jaipur, Jodhpur is worth seeing, and on the banks of the Jaisalmer. And I really wish you all to come over, taking some extra days, come over, attend a conference, and move around in the Jaisalmer desert and see the Rajasthan in its beauty, because the weather at that particular point of time, when the conference goes on, is absolutely lovely and enjoyable. So I really appreciate you all coming out and welcome you all. The other thing which we started recently is a postgraduate assembly, taking steps from the new your postgraduate assembly. So there is something called the NYPDA, called the New York Postgraduate Assembly, started by the American Society of Anesthesiologists. And we also started after many years of planning. We started last year. It went very well. And this year we are repeating the same. And probably this postgraduate assembly is going to be every year as a continuous program and going to be in Delhi. And this year, in addition, we may do it in Bangalore also. Bangalore dates are not decided, most probably June or July, whereas the dates for the Delhi is already out, is already being shown as 25th to 29th April, 6 days program, and is one of the best examination, coaching, or finishing type of assembly where one should not miss. Here also, there's a limitation of seats, so please come and join. This is going to be at University College of Medical Science, Shadra, and Delhi. And time April, well, the winter is coming down and the summer is slightly hotting up. Probably one of the best seasons for Delhi for those people who are from outside Delhi to move around in Delhi and see the place. And the other program at Bangalore, well, we're going to tell in another 3 weeks' time when the dates are going to be decided. And apart from that, the college is running many courses, short courses. I mean, certain areas in anesthesia where we don't have any academic course as such. We have taken that particular sub-specialization area and we have doing courses in cardiac anesthesia, pediatric cardiac anesthesia, onco-anesthesia, palliative care, obstetric anesthesia, difficult orthopedics. Well, all these are being run. And for more information on these things, kindly refer to our website. All are 1 year long courses. Sometimes some course may go beyond 1 year, but all are accepted courses and recognized courses everywhere. And with these words, I request Dr. Rakesh Garg to start off with today's program and wish you all the best and wish you the happy Public Day of Remembrance and see the parade on 26th morning, how we and our country are parading for all of us. Thank you. Good night. Dr. Garg.
Thank you so much, sir, and thank you, ICA, for this initiative and many other initiatives for spreading academic knowledge across the globe. And thank you for all the introduction. So in today's session, we'll be talking about 2 key aspects of systematic review and meta-analysis. To begin with, we'll talk about the basics that we need to understand about the systematic review and meta-analysis. And in the second session by Dr. Tantry, we'll be discussing about various key aspects when we report systematic review meta-analysis or when we read that what are those do's and don'ts that makes us understand to do or report systematic review and meta-analysis in a more acceptable manner with some information that can improve our patient care. So let's begin with the basic aspect. So when we talk about the practice in anesthesiology or perioperative care, we talk about the evidence-based medicine. And all our clinical management is primarily based on the evidence-based management, evidence-based medicine. And this evidence-based medicine is primarily the involvement of various aspects. This is the best evidence that we have in combination with patient values and expectations. And it also incorporates the clinical expertise to make something which is the most suitable one, and that gives the best possible care to our patients. Now, can we get it from the various studies? We know that RCT or randomized controlled trial are one of the robust type of studies. So what are the problems with them? Why can't we just look into those RCTs and take some conclusion. The RCTs has its some inherent limitations, which preclude us to take their conclusion and translate into a clinical practice. And these are the main reasons for it. Probably there are many other, but a small sample size, regional area, a single center, probably the publication bias that only the positive studies are preferably published and the vice versa are not. And this makes the implication or the clinical translational value of a single study into clinical practice a little doubtful. And that's the reason we need to look for something else. And this is what, when we talk about evidence-based medicine, we need to ask that what my clinical problem is. And then we try to acquire the evidence. And this is what, when we say evidence, it is not the single evidence, but it will be a combination of evidence from multiple places so that its generalizability is much better. And then we try to synthesize something from the evidence that we collect and then apply the best evidence and give the best clinical care to a patient. And this is wherein the role of systematic review and meta-analysis comes in, because we have to synthesize those evidence from the available evidence that we have. And this requires the pooling of data or the reanalysis of the available studies to come out whether all the studies are going in the same direction, to give us some clue that this possibly is the best drug, it's the best possible strategy, best possible technique, or any other thing. And that's why when we talk about the evidence-based pyramid, the meta-analysis remains on the top, because it incorporates or it removes the limitations of single studies. Even a well-conducted, robust randomized control trial, it will have some limitations. But when we combine multiple of them and try to reanalyze them, probably the meta-analysis is one of the topmost, which gives us the best evidence. Now, systematic review is basically, if we want to define it, it's a review that is conducted according to a clearly stated scientific research method, and it is designed to minimize biases and errors inherent to traditional narrative reviews. And the review of the evidence on a clearly formulated questions, you must have heard about PICOTs. So we have a clearly formulated question, and once we have it, we use a systematic and explicit methods to identify the primary research, extract and analyze data, and try to conclude from it. And this becomes systematic review and meta-analysis. So when we say systematic review, probably we can have a qualitative synthesis or a quantitative synthesis from various data, which is called as meta-analysis, which gives us more robust conclusion from the available studies when we try to do a meta-analysis. Now, when we understand or when we read it, or when we conduct the systematic reviews and meta-analysis, we have to understand certain concepts. One is the applicability. Why should we do it? Or if we do it, how to critically appraise it? Now, it should have an answerable research question, which is clearly defined and is something which we want into our clinical practice. We're in dilemma that whether to use this drug or not. Some study says use it, some study says not for benefit. And this is what we get a clearly defined answerable research question, whether this drug is useful for this particular beneficial outcome. When we do the analysis or the evidence collection, probably whatever the research is, whether it's a randomized control trial or observational studies, and even for SRMs, we need to understand that we need to reduce the bias that is inherent to these type of researches. And that's why we should be very, very clear. And we have to take certain steps during the studies to look that these biases are kept to minimum. Probably we cannot make them zero, but yes, we have to keep them minimum. Now, once we say that we have answerable question, we have taken all strategies to reduce the bias. Now we have to collect the whole evidence. And we know that some studies would have been done in India, some would have been done in Europe, some in Australia, some in UK, some in different populations with regards to geography, demography, races. So when we try to collect those evidences, probably the generalizability becomes better, and we need to collect all the evidence from all the literature, and that requires a special strategy. And this should be done in such a way that this is replicable. So everything has to be disclosed, everything has to be done stepwise manner. So what is required when you want to conduct an SRMA? It is you identify your studies, determine the eligibility criteria, what needs to be included, what need not to be included into your SRMAs. It has to be decided a priori. Then extract data from the studies depending upon your primary objective of the SRMA, analyze the data, and then try to interpret with background of some clinical information. So this is the broad outline that we do. And the basic purpose of meta-analysis is that we are able to reach some definite conclusion. As I just mentioned previously, sometimes we get equivocal outcome. Some says very, very significant. Some says highly clinically significant. So we get studies which probably sometimes gives variable results. And that makes us confused that which is the best study or which conclusion should we follow. And this is what, when we try to pool those old data from those studies and try to make a single conclusion, this is what meta-analysis is. So this is a quantitative approach for systematically combining results of the previous researches to arrive at a conclusion of whatever the primary research question you have thought of. Now, this is, when we talk quantitative, means numbers, systematic means methodical approach, combining means all the studies that are available to us, previous research means what has been published across the globe, and then we reach a conclusion which gives us some information. So this is what, if you put up a broad reviews, what they are. Narrative reviews are so many, but if you do it systematically, methodologically, it becomes systematic review. If there are some basic requirements fulfilled, we can do a meta-analysis. So this is what the reviews are, and this is how we can do for. So let's start how to do it. So this is, as I mentioned, that the systematic review means something has to be done systematically in a structured fashion. What needs to be done? Formulate the research question depending upon your need, depending upon your clinical problem. Plan the review. Do a comprehensive search from various search engines which are available to us. Unbiased selection and abstractation process. Critical appraisal of those data with regards to bias, the qualities. Synthesize the data from these studies, extract them, and do the synthesis, which is called meta-analysis. And whatever the data we receive, and depending upon the quality of studies, depending upon the evidence, depending upon the biases it has, we interpret the results and then reach a conclusion. So this is what systematic review is. Now, when we start doing it, as I say, it's methodical, transparent. So that's why when we do a systematic review and meta-analysis, it should be registered into some online registry program like Prospero. And this protocol ensures that everything has been decided, everything is methodological, everything is systematic. And then do rest of the procedures which I have just told you, and then it can be published as full paper. So let's see these aspects, how to get started and what needs to be done. So what needs to be done is, first is we should be sure that nothing of similar research question has been analyzed by other authors as the systematic review and meta-analysis. If somebody has done it, that's why we have registry. We can see if somebody has done the systematic review and meta-analysis on a same research question, need not to repeat it. So you can always go through those websites like Prospero, where all those SRMAs are registered. Then look for the methodological guidance. It has stepwise approach. If you have seen something like Prisma, Prisma P, they gives you all the components that must be incorporated. And this is what the methodological guidance is. We have to follow those steps so that it is systematically done. And then there are certain reporting guidelines. Most commonly being used is the Prisma, which is being done for majority of the SRMAs in medical sciences. Then there are specific one which can also be used like Coster, Antrec, Messer, Mercier, Moose, Neros, Roses, Swim. These are modification which is specifically for a particular purpose, like COSTER is for toxicology, MOOS is for observational studies in epidemiology, SWIM is wherein you want to do a meta-analysis, but there are certain limitations, and you synthesize data, but you don't meta-analyze them. You have to apply SWIM protocols. So these are the reporting guidelines, which gives you a clue that these components need to be included when you're reporting your SRMS. Now, the scope of a systematic review is defined through two basic aspects. One is the research question, and second is the eligibility criteria. When we say a research question, it should be an answerable one. Means when we have some clinical problem, when we are looking for that, do I have a drug? Do I have a technique? Do I have a strategy that will improve the patient outcome with respect to any outcome parameters? Think of those things. Simultaneously think that whether some people have attempted answering them by doing certain studies, because we will need some studies. So had it been absolutely a novel idea which nobody has thought of, probably it will not lead to you SRMA. But yes, probably some people in some part of the world must have thought with the similar ideas, with a similar clinical problem, and then probably some studies have been published, and you can do a APRI literature search to know about it. If you're not keeping yourself updated by reading the journals regularly, then start thinking of, and this will make you something which will help you. So when you start thinking of those areas, clinical problem, it has to be put into a statement. And this is usually in the form of PICO. So this means when you frame a research question for systematic review and meta-analysis, it should have some basic ingredients so that you can do a good methodological exploration of your research question. And this PICOT format, as you do for your randomized controlled trial, will have basic components. And these components will be inclusion of the population, the intervention, the comparator, and the outcome. So you have to look for those things. And there are other options also which people uses for SRMS like SPIDER, CIMO, 5Ws, and HS. You can use any of them, but most commonly being used is again the PICOT here. And when you define your research question for the SRMA, ensure that all the components are incorporated into the research question that you have. So this means if you're looking for, say, effectiveness, you need to mention which population. Say, for example, are you looking for the obstetric population? Are you looking for laparoscopic abdominal surgeries? Are you looking for lung surgeries? So you have to define those population so that you are getting a little homogeneous type of studies included into your SRMA so that you can answer your research question well. You also need to identify the intervention. Say, for example, you are using drugs for a particular aspect, say pain management. If you're looking for adjuvant, you want to look for whether magnesium is more beneficial than lignocaine. Recently, for last couple of years, lignocaine is being considered for oncological surgical procedures. So you need to identify whether those interventions are really helpful. And then you have to compare with something. Then only you can say it is beneficial or not. And this comparator could be sometimes placebo, it could be sometimes a standard of care, or it could be a gold standard. So against which you compare that whether this new drug or new technique or new strategy or new intervention is better. So that's why we have to define them, that we are comparing this technique or this drug against which, and that is what the C stands for. And we should have properly predefined outcome parameters also. What are we looking for? Are we looking for the length of hospital stay? Are we looking for mortality? Are we looking for pain scores? Are we looking for decrease in the consumption of opiates requirement as a rescue analgesia? Depends upon what type of clinical problem and the research identifying. You need to define those outcomes objectively so that you get appropriate studies and you can extract data and can make some meaningful conclusion. So this is what we talk about the PICOT statement here. These PICOT statements will include the PICOT, and probably sometimes time factors also comes into the picture, wherein say you want to say that the PNV at 12 hours, PNV at 24 hours, neuropathic pain at 48 hours, chronic persistent pain at 3 months, 6 months. So you also need to define into the research question itself that what time frame are you looking for your outcome. So this is what needs to be defined. This is the initial step. Once you have identified your clinical problem, this needs to be done subsequently. So there could be many things. There's certain examples I've given related to the perioperative medicine. There could be anything depending upon what type of. Also try to identify these type of studies, because in the beginning I just mentioned that we have to use various reporting formats which are different for different studies, whether it's randomized controlled trials, it may be observational studies, it may be toxicology related. So you need to identify those things, whether in this systematic review, what type of studies will you be including for answering your research question. Once you have identified the research question, you have framed the research question, now you need to look for the eligibility criteria, that what research needs to be included into a study to answer your research question. And the eligibility criteria are primarily, as you do for RCTs, inclusion and exclusion. Are you audible?
Yes, sir. Now,
Madam Gupta, am I audible? Can you hear me?
Rakesh, you are audible. Go ahead.
Right. Thank you.
Video is not there, but you are audible.
So when we talk about the eligibility criteria, we need to look for that what type of studies need to be included here. And this is what we talk about the inclusion criteria and the exclusion criteria. So these criteria needs to be predefined, that what type of studies are you going to include into your systematic review and probably the synthesis of data. And they should be decided a priori when you make your protocol. Now the eligibility criteria, it should be very clear, unambiguous and easy to apply. And that is what, based on your experience, based on the initial review, you can always decide that what type of eligibility criteria are you putting up, so that you can get sufficient papers to make some conclusion out of it. And then you frame your protocols. When we talk about protocols, there are certain reporting guidelines for protocols also, like Prisma P, that will help you to make the protocols so that you can you are not missing any important aspect out of it. And then try to write it and ensure that all the components are there, so that you are not only ensuring transparency, but you are following the methodological requirement of all the components here. So once you have done it, now it's a time to find the evidence and try to search for it. So when we want to search the evidence, we have to look for where, how, which type of literature, and sometimes there will be some corrections in the published literature we need to look for. Now, there are certain well-known search engines which are available, which are reliable, and you need to predefine them, which are those search engines you're looking for. And these search engines have peer-reviewed various databases, various published literature that makes you look for those evidences and then make some conclusion out of it. So this is what you need to look for. And when you start looking for those databases, you can look for like say PubMed or Medline, AIIMS, Cochrane. These are the standard databases where you can explore them to find related research based on your research question. And when you try searching those databases from the search engines, you have to decide certain so-called keywords or concepts so that whatever the research question you have, you are able to put them into certain words depending upon the requirement of those databases so that you can get all the relevant research which has been published related to your primary research question. And that's why these are called concept-based models, like concept 1, concept 2, concept 3. You think of the basic keywords, which is based on your research question. Think of all the synonyms that you have. Use the Boolean operators with them, where you want the combinations of them, and make your concepts so that when you put those search string into those databases, you get probably the published research available to you. So this is what we have discussed till now. You identify your clinical problem. You identify PCOT components, start with primary concept, look for synonyms, add other components of 5 question narrow citations, and then subsequently, when you have used those databases to identify search, look at whether those abstracts or the titles or the papers that has come from those search engines suits to answer your primary research question. And this is what you can use some filters at time. I mentioned in the beginning that sometimes you need to look for the type of studies as your inclusion criteria, whether they are RCTs, non-RCTs, observational studies, cohort studies, whatever it is, you can identify them. And there are various literature which are available with regards to these study design filters. And even in those databases, you can always put those filters to identify the type of studies that you focus to include into your systematic review and meta-analysis. And these are the sources that you should also look for, because sometimes the studies will be ongoing. They may have published versus unpublished data. They may be present into, say, certain repositories. They may not be into, you can say that, 1 search engines or 2 search engines, or they may be in peer journals. So you have to look for all those things. And sometimes they may be in the form of dissertations, thesis, or just in the form of conference abstracts. Probably full paper may not be available. So look for all those things so that you have a comprehensive search of all the evidence existing based on this. Probably your librarians can help you to identify those things as well. So once you have looked for those things, then try to identify and go through various titles and abstracts. This is the first step, to look for whether the database that you have searched for, which have identified certain published literature, corresponds to your research question or not, corresponds to PICOT or not. You need to remove which do not matches, and you need to include which matches. Sometimes there may be confusion that maybe or may not be. In those situations, probably more than one reviewers can review, and then it can be discussed and taken a final decision. Once those has been screened up, then you go for the full text review, again to see that it matches your eligibility criteria. So this is what we have discussed till now about the screening process for SRMA. You identify the read duplicates, you identify the titles abstracts. If they do not matches with your primary research question or PICOT, exclude them. If they're unclear, have discussion among the researchers, look for the full paper, and then take a decision. If they matches, you include into your systematic review. If there are certain things which has not been reported appropriately, you can always think of how to include them, and you can always contact the authors to identify other informations that may have been missing in these publications. So this is what all needs to be done for the systematic review and the meta-analysis procedures. And once you have all those studies, you can identify them. And this is how you record it, because the process has again to be transparently reported, And in those situations, you can use this type of chart, which is called Prisma flow diagram, wherein you can always try to identify the process that you have looked for, and you can always you have always to report that how many literature, how many things you have identified, what was excluded, why was it excluded. Everything needs to be reported in this flow diagram to maintain the transparency. Now, this is again sometimes when we try to look for certain registries. So this is again the flow diagram, which is for new systematic reviews where you need to retrieve data from multiple places. So these are the formats which are available in various databases, various statements where you can use them for reporting your research methodology for SRMS. Now, once you have looked for, when you identify those papers, you have to appraise them, because each paper may not be having the highest quality. There may be certain bias into it. So if you analyze those papers and put them into the systematic review and meta-analysis, if the quality of paper is not good, we'll not be able to make some conclusion. And that's why we have to do something to appraise each paper. And this is, we have to identify the risk of bias. And that's why the whole process that we are looking for step by step is to avoid any bias creeping into our SRMS. And that's why we have to look for various tools. So we have initially mentioned about the looking for the paper, looking for the PICOT, matching the research question. But once we have identified them, we have certain tools which are available. They are software-based tools which can identify based on certain entries that you do from each of the identified studies and try to see that whether they have some issues of bias or not. So these are the various tools which are available, like Robust, Robbins, ROBCO tool, which can be used for different type of studies. And these will identify at what level of bias exists in these studies and whether you should even include them into the meta-analysis or not. So this is what various parameters will come up. When we say RCTs, we always talk about that you should report the blinding, you should report the allocation concealment, you should report the various biases, the data collection, the loss to follow. So this data from individual study will be identified, put into this software, and this will give a fair idea that whether a risk of bias exists for a particular study or not. We can also look up a funnel plot. So when the studies are appropriated, this will appear like a funnel here, and this will indicate that the publication bias is not there for that particular research question for which you have identified various existing research. So this has to be done because when we talk about the reporting bias, because of many reasons, the word limits, the negative studies, the peer reviews, the type of journals. So these type of biases can happen. So we have to identify these type of biases also. And this type of statistical tool will help us to identify whether this bias is there with this research question or not. Now, once we have done it, this type of funnel plots, which is more of a funnel, will give us a fair idea whether the publication bias exists or not for our studies, right? The second aspect that we need to look for is the heterogeneity, because many of the journals may be publishing this literature, and there will be a lot of differences in each of the individual studies. So when you try to plot them, you will see that if the heterogeneity is there, it disrupts the funnel shape. And then it will identify that probably taking up the data from this individual study may not give you an absolute conclusion, because there has been a lot of things. And then even for SRMA, there are certain tools which we'll be discussing in the next session that will help us to even take some measures statistically to look for this aspect also. So once we have done it, we need to extract the data and then do a synthesis analysis, because we have identified studies. We have looked for the quality of these studies. Now is the time that, since we have identified well-conducted studies, we need to pool their data to look for some effect from those published literature based on your primary outcome, based on your primary research question. And then based on this, you can always try to extract data and then try to analyze them, then try to synthesize those data based on your primary outcome. And there are certain tools which are available. Raman is the commonest one, but there are others one which can also be used for synthesizing data from these published literature to reach some conclusion. So this is what we have discussed. When these type of data comes up, we try to put them into a certain statistical tool, we get some data, and this is what comes up. So there are certain things we talk about. The length, you can see a horizontal line. We see some squares. They are of different shapes. On the bottom, we see a diamond. And we also use sometimes the odd ratio, relative risk, confidence interval. So these are the technical terms that we use them. And based on this, we can make some decision. We usually identify a line of no difference and then or line of no effect. And based on this, where these diamond shaped structure lies, or where these you can see the thick squares, where they lies on which side of this line, their thickness, and the confidence interval is spread. So based on this, we can always analyze them, that whether whatever the primary research question we have thought of is beneficial, that is the intervention as compared to comparator of PICOT is of any difference or not, and then we make some conclusion. So this is what this forest plot looks like, and based on this you can look for. And also I was talking about the heterogeneity, that these studies are very heterogeneous with regards to various aspects, patient related or intervention related, and then we use certain tools for identifying this, and I-square is one of them. And this will identify that this will have, say, a 60% or 80%. If it comes up, this means there is a lot of heterogeneity into these studies, and hence becomes difficult to make some confusion. So this is what a simple example which we have just mentioned for you. So when you plot them into this forest plot, and this is how it looks like. If you see the structure or the length, the horizontal line, which indicates confidence intervals, the square, which gives the weight of that particular study. Based on this, you can just make some confusion. If they are favoring totally from one side without crossing the line of no effect, probably they are beneficial. If they are thick, their weight is more, and if they have less dispersion, definitely it is almost beneficial, as you can see on the topmost. And this is how you take decisions. And when you synthesize and collate all the data, you get a small diamond, which I have mentioned earlier. So this is how you have initially systematically collected all the published literature, extracted the data from them, analyzed it, and then start thinking of what the various effect measures related to your outcome in the form of risk ratios, odds ratios, risk difference, some also called as absolute risk reduction. This depends upon what outcome are you looking for. And based on this, you can always look for the certainty of evidence. You can always make the certainty of evidence using the GRADE, which is a tool which is used for assessing the quality of evidence. And this is again available in various online software tools where you enter the required information and you get the information. And based on this, you can always try to look for the quality of evidence that you have generated, whether it's high, moderate, low, or very low. Now, the heterogeneity is again a basic issue. It could be because of the clinical heterogeneity, the methodological heterogeneity, or statistical. So when you look those papers which you have included, you need to identify those things. And based on this, you have to make a cautious decision of the conclusion from your study. And there are tools to identify them. We have already mentioned them. And the I-square statistics is from the commonest one. So this is what is the complete table that you get out of your synthesis, which indicates various aspects which I mentioned about. The forest plot with the weights, with the odds ratios, the in confidence interval from these 5 studies are being mentioned. And if you see this, this means if you see the diamond, which is the lowermost mark in this diagram, this means whatever the things were comparable, the treatment versus placebo, the treatment or the intervention was favoring the treatment as compared to control. and hence you can conclude. So this is what you can always think of when you're looking for the systematic review and meta-analysis, and take a decision based on various parameters that you get out of this synthesis. Now, heterogeneity, I think we'll be discussing in the next section a little bit do's and don'ts. But when you talk about heterogeneity, try to identify what is the reason for it, and sometimes they can be taken care by subgroup analysis or sensitivity analysis, and then try to look for. And once you have everything is done, you need to report your SRMAs. There are standard tables. If you just follow the Prisma guidelines, reporting guidelines, you'll be able to identify them. You have to report them into various things. Now, this website, Equator Network, is a good website. So whatever I talked today, majority of things are given on this website. You can go through them. You can identify your concerns, you can learn from them. There are certain reporting guidelines. The details about tools are also mentioned there. You can just go through them, download them, and try to read them so that you understand your SRMAs. It is equally important to do an SRMA or to read an SRMA. A basic knowledge that we have discussed today is helpful to you. So thank you once again for joining today's session. And now we will move towards the next session, which is in continuity of it. So what we have discussed just now is the basic aspect. So what are the components of SRMA? There are certain nitty-gritties. There are certain do's and don'ts. There are certain basic aspects. Let's see what those are. So may I request Dr. Tantry, who is one of the experts in not only doing analysis, but he also one of the popular reviewers and giving expert comments with regards to systematic reviews and meta-analysis. So I will request Dr. Tantry to take us forwards on other aspects of systematic review and meta-analysis. Over to you, sir.
Sir, good evening, sir. Rakesh, sir, actually, long time. Radhakrishna, sir, and my senior professors, and of course, my friend, Dr. Sanish. Good evening to everyone. I'm just sharing the screen. 1 minute. Screen, no, sir, in this? To share?
There is option on the lowermost green one. If you just press it, you will be allowed to share.
Entire screen.
Yeah. Perfect, sir.
Yes,
It's
sir.
visible.
I'm audible, sir?
Yes, sir. All clear.
Yes,
Audio, video. Perfect.
Yes.
Sir. Good evening, sir. Actually, if you look at the topic, actually do's and don'ts in the meta-analysis. Sometimes when I was typing, I was wondering whether I'm writing as don't do meta-analysis. Okay, so I was confused. And my disclosure is all the examples I put here in some of the meta-analysis presentation. Actually, do not represent any of the specific papers. It is only illustrations. And of course, I want to tell you, sir, actually, I am not a statistician, and you have given more introduction, or I am overwhelmed for the same. Sir, what is there in this topic is do and don'ts. So I should be telling some errors of writing of a meta-analysis, errors of data synthesis, or how we interpret the results and analyze the result. And there are so many errors in the conclusion what we make, and sometimes, of course, the reasoning of a meta-analysis. So what actually these slides may help probably to improve the quality of publication if we attend these things. Okay. So I divided the topic into some part one and part two, where actually part one already Rakesh sir has explained already, and some of the errors of part one, I'll just brush through the slides. In the part two, some of the significant errors which can otherwise make the interpretation and or the results and unable to interpret and make any conclusion. So these are the errors which we commonly see. So that's why I divided the topic into two headings. The like any other meta-analysis, all the studies are we start with the title and introduction. This is the one of the area where actually we require to look at the authors for their actually headings. Now, if you look at this, both of the uh, titles appear same, comparing the one drug to the another or one method of anesthesia to the another. But what has actually happened when we see this type of comparisons, these titles appear very straightforward, but sometimes can mislead. If you look at the second one, the both methods are equally important or both are non-inferior to another. So that time the conclusion based on this type of meta-analysis will lead to a question for the reader whether which one is important. It is always better to better not to write as a comparison of one method to another. Instead of we can highlight the title as effectiveness of one drug or effectiveness of another drug over the other, which is superior. So the title itself will give the idea about the whole entire research. For example, last as I have shown here, the meta-analysis of a cognitive behavioral therapy in the reducing the depression. See, they have not written any title relating to the comparison. But in some cases, we still write such as the titles of the airway measure methodology. If you look at that, so the supraglottic airway device, which is uncommon in a cesarean delivery. So the common technique is to do the endotracheal intubation. So in such cases, it do well. But in majority of the titles of the meta-analysis, when the one method is when not superior to the other, it is better not to mention as a comparative. As with the title, the introductions also sometimes it looks little difficult for the acceptance. Now, most of the time, we are getting updated meta-analysis because the research question has been already addressed probably a few years back. After some years, the additional literature will be added to the same topic or same subject. Now, the reviewers or editors will be usually interested in to know what is there or what is different from the previous publication, whether that review includes or excludes those articles which are included previously. So these are very important for us to consider a meta-analysis. Most of the time, authors will not make any attempt to consider these points. So that this has to be corrected in this introduction part. Now, with the definitions of so many primary and secondary outcomes. Now, we are dealing with many meta-analysis which defines the primary and secondary outcome. Now, what has happened? What will happen is the different studies will contain different methodologies for their definitions. For example, if one author in one of the study defines a sensory onset or block time as a duration of the sensory block which regresses from S1. Now, another author will address the same issue in a different part. For example, he will define as a T12 or L1. Now, similarly, motor blocks. One author of included study will define the motor block as a Brome square 1. Another author will define as a Brome scale 3. So these differences will not be addressed by the authors, and these has to be primarily defined by the study authors. There are two authors. One is the person who is doing meta-analysis. Another is the author of the included studies. Now, there is a difference. There will be a difference of definitions for each study. So in the such cases, it is better always to write that the duration of the analysis or anything, it is better to write as the primary author who defines it. Okay. Now, sometimes the authors will define difficulty in to define the endpoints. Endpoints means if the author defines his endpoint. For example, let us take nausea and vomiting. Now, when we consider nausea vomiting, the author will define the nausea one 6 hours. Another person will define the nausea vomiting for the duration. Study authors means the person who does the one study, he will include for 6 hours acceptable. So what our meta-analysis is separately. For example, what I shown here, 3 days separately, and the conclusion will be different. So that is why the defining an event. In one of the study, the authors will define the heart rate as less than 50. Another author will define the heart rate as 60. So if you club the incidences for these bradycardias, for example, when we consider the odds ratio or risk ratio, so this time the results definitely will differ. So these are the two areas actually the authors need to address. Now the most important thing is during errors in the data synthesis. Now we get to know we don't get the individual data for the patient in the many of the meta-analysis studies. So what we get is the pooled data. Pooled data means it's a standard error of mean or standard deviations we get median or mean for the different studies. Now, authors directly enter the standard deviation if the study author has reported as a standard error of mean. For example, if the median is provided and mean is not provided, and we need to enter the mean value in the Revman software while conducting the meta-analysis, instead of entering the mean, the same median value will be entered. Now, whether this is acceptable or not, till last 2 years, the Cochrane has guidelines has said that median can be entered for the mean. But last 2 years, they do not advise or they advise against this. So the data conversion tools are available on the internet, and these can be used for the conversion of data and then enter into the software. That will be easier. Many errors will happen during the incidence calculation. For example, if you look at the table, now one drug has caused 4 times nausea and 3, and another drug has caused once nausea and vomiting 6 times. So the nausea incidence is higher for the drug A. In contrast to this, the vomiting incidence is highest for the drug B. In such cases, can we enter the data? Now, if we are supposed to enter the data in the software, now which one to consider? It is a very, very peculiar situation. So, it is better actually, we consider in such a situation, it is better to consider the highest number of occurrence of an incidence and enter into the data. See, we cannot club nausea and vomiting together because it is because the same person who experienced nausea might have vomited later, and vice versa. That is why we cannot club the data. So the individual decision or intellectual decision of the author is very important in such cases. That is why the handling of the data is important. Addressing some publication bias also important. For example, you can see this forest plot where two incidences are compared for the two different levels of EtCO2. One group has received or maintained with higher values of EtCO2 intraoperatively, whereas the other one is with the lesser value. Now, if you look at the data and comparison, statistically, the incidence of an event is not different between the groups. The diamond is touching the midline, and there is no p-value is not significant. Now, you can see, go through all the studies. Now, what has happened? The second study, which is depicted here, has got a significant outlier. Okay, so now if you consider all the studies together, the p-value is not significant. That you can consider that there is no difference between the two groups. However, if you exclude that same study, if you exclude the same study, for example, in the second graph, I have excluded the data, and you can see what has happened. The diamond is not touching the line. So whereas in the previous graph, it was touching. For the same data, the p-value has become significant and statistically. So the entire conclusion of this meta-analysis will change just because of one additional study data. So such publication bias are not addressed by the authors. If that is so, the reviewer has to consider all this before accepting the paper. So such publication bias needs to address. Now, method of analysis, sir, Rakesh sir has already addressed some of the things here, but I still just go through the some of the aspect of methods of data synthesis. Now, commonly used method in the meta-analysis, I think the authors who know about the meta-analysis, I think they will be very familiar with this, whether to use fixed effect models or random effect models. These are the basic steps in the meta-analysis while conducting or deriving the effect estimates. Now, in general, you can see this forest plot. What has happened now? I square value is very high. It is at the bottom. So you can see that. So what has happened? The I square value is high. You can see that midline from the or away from the midline. There are several studies are the effect estimates are displayed. Now, how do we handle this? The author has used the fixed method of meta-analysis. That is why the p-values has come very, very highly significant. Now, the conclusion is there is a difference between the groups. Okay. Now, I have used a different method, not the fixed method. So I have used a random method and effect method and shown here. So this is the first graph displays the random method and the second graph displays the fixed method for the same study. Now you can see the difference in the p-values. And in one meta-analysis forest plot, the diamond is touching and the p-value is not significant. And another, the diamond is not touching and the p-value has come highly significant. The heterogeneity remains same in the both. So using a fixed or random method is very, very important to and addressing the heterogeneity here, which I am going to discuss in the next few slides. Now, similar to fixed or random, there is a risk ratio or odds ratio differences. But however, this will not usually affect so much the effective estimate. More or less, it will be same, and the p-values will remain same. But in general, it is better to use the risk ratios when the incidences are very high, because odds ratios can overestimate the effect estimates compared to the risk ratio, especially when the binary data is there. So it is better, I think in general, every statistician or every researcher will know where to use risk ratio or odds ratios. Now, one effect estimate in general and 90% of the meta-analysis will derive is the mean difference. The mean difference has got a most of the time mean difference will be wrongly displayed with respect to the data entry. Now, alternate for a mean difference is the standardized mean difference. Now, you look at the graph of forest plot of the mean difference which I displayed. Now, this is the first graph and this is the second one. The first displays the studies which contains the perioperative opioid consumption of for two groups. The second also with the same study, the second also displays the same thing. In first graph, we have used mean difference, and in the second graph, we have used standardized mean difference. Now, where is the difference? The difference is the data entry. When we enter the data, now we have entered 40 milligram of morphine used, 3 microgram of sulfentanyl or 300 mics of buprenorphine. So the different drugs have been entered and with the different what is that different milligrams or micrograms, okay, units, or what we call as units. Okay, now when we use different drugs, it doesn't mean that we have to use the standardized mean difference, but when we use different units, we require to use the standardized mean difference. The fundamental principle of understanding of different data entry here is very important. So otherwise, what will happen is the end result. So the statistical difference will be obviously seen if you wrongly enter the data. So one will get the p-value highly significant, telling that there are differences between the groups or different in the methods of what we used, and another one is non-significant. So what happens is just by changing the mean difference use or standardized mean difference, we can change the results what we obtain. Now, so how to solve these problems? So it is better in such cases. It is better we use the equipotent doses of analgesics of opioid and try conducting the meta-analysis. So I brushed through the part one little more faster than I anticipated, and we'll move on to part two, where actually the more important statistical analysis has to be addressed. Now, if you look at this forest plot, now the several studies have been included for this forest plot with the laparoscopic surgery or open surgery. Now, what has happened? We have here all the data entered. Now, the ETCO2 value again I showed of with the high and low values for the two groups. Now, the diamond is touching the midline, and we have the p value not significant. Now, when we club this type of surgeries, with both laparoscopic as well as open, we are getting the statistical value which is not significant. And of course, I square is the inconsistency value, heterogeneity. It's very, very low, 0%, and it appears to be a very good study. Now let me move and split the groups. I will separate it so that laparoscopic falls into another one and the open surgeries fall into another one. Now what has happened here, you can see there that diamond is not touching the midline and the p-value has come significant. So when we split the groups for the open surgeries, the diamond is touching the groups and the p-value is not touching the, p-value is not significant. So what does it mean? Separating the groups with the higher and lower ETCO2 values, there is a difference of the event, perioperative event, what we can see here. However, if there is an open surgery, there is no event difference between the groups. That is the main finding. Now, if you do not separate it, then if you club, again we saw that there is no difference. So sometimes authors will fail to segregate the type of surgeries, and of course you cannot club apples and oranges. So laparoscopy and open surgeries cannot be clubbed, and it will definitely change the p-value, and therefore the final conclusion what we make at the end of the study. So this type of analysis we call a subgroup analysis, and subgroup analysis is must in any meta-analysis, because there will be difference in the type of or methodologies applied by the various studies. So as Rakesh sir already said about the inconsistency values or heterogeneity, this needs to be addressed. So let me take separate again open surgeries. You can see that I square value is very high and inconsistency. Inconsistency definitely defines this placement of this bars, effect estimate bars with 95 confidence interval. So when it is not overlying to each other, it is separated, the inconsistency values come high. Now, this type of inconsistency, how do we address? We require to address all these inconsistencies in this meta-analysis. Not unable or not attending the inconsistency leads to errors in the meta-analysis. But one thing is that we cannot always explain the inconsistency, but the paradox is the inconsistency cannot be always explained. That is also a problem. So, do we think that inconsistency is a bad thing? No, it is not bad. However, we require to explore further what is the reason for inconsistency in every meta-analysis. So for example, okay, now if I am exploring the inconsistency in heterogeneity, now should I do a subgroup analysis? Of course, a subgroup analysis is a definite idea of evaluating the heterogeneity. So if I take a group of surgery, now everything is laparoscopic surgery, still my inconsistency is high. What should I do? Now here is a problem. Now this forest plot indicates the pain scores for the two groups, post-operative pain scores after we maintain the ETCO2 value. One group is for higher ETCO2 value, another group for the lower ETCO2 value. Now what we can see is definitely there is a difference. The person who is having a lower ETCO2 has got a higher pain score. Okay, so there is a p-value significant, but I really require to explore this heterogeneity because it is high. It is more than 50%. In general, we explore it more than 50%. Now, how do we do this heterogeneity evaluation? When we cannot perform through the subgroup analysis, we have to go for something called meta regressions. This is what is more important. Now, if you look, how do we do meta regression? Now, if you place separately all the studies and explore further, now each study will have a different method of opioid use. For example, one of the study has used fentanyl, another has combined with nitrous oxide intraoperatively, another has used PCA morphine, some have used fentanyl, or LIS they have used. So if you explore further, the inconsistency will be definitely evaluated. So this method of analyzing we call as meta regression. Unless we perform meta regression, we will be unable to find out what is the reason for the inconsistency. Now, if you explore this paper, for example, the previously I explained for heterogeneity, the same paper. Now, if you will find the higher ETCO2 value was used with the morphine. So most of the people have received morphine. So it is not the higher ETCO was causing the pain increase. Lesser pain. Instead of that, morphine was causing less pain compared to other opioid analgesics. So after we find the higher inconsistency values, we'll definitely, if you perform meta regression, we'll be able to get to know. There are different type of meta regressions, single type or multiple, which I don't require to. I am not going into details. Now, while performing meta regression, it is not very, very difficult for the authors. If the authors want, then using a software which is freely available. So this software, if you get the meta regression table incorporated into this, it's very, very easy to perform a meta regression. This is a table which I have shown here. It is a meta regression table which I have obtained. How do we get this table? Who will enter this table? It is very, we are not going to enter this table, this data into this table. Actually, it is directly obtained from the Raymond file. The person who does the meta-analysis, he will use the software of Raymond. So the same Raymond software, we can export this file. This is called csv.file, which can be directly incorporated into just software and conduct the meta-analysis. Now, after the meta regression, the one more point I want to highlight is the sample size. The sample size we don't call as a sample size here. We usually call as the required information size using a technique called trial sequential analysis. Now, the sample size is usually calculated for RCTs. So every RCT should have a sample size calculation, and we'll come to know what is the power of the study and other details. So similar to this, in the meta-analysis, the RIS is calculated. Now, RIS usually it will be calculated or counted after the performing or after conducting the meta-analysis. Now, my meta-analysis is there whether I have achieved the required information size. For example, you see here two tables are there. One table contains 4 studies and another table contains 5 studies. The first table or the first plot has got a samples of only 134 for the each group. Another got a somewhere around 250. Now very limited number of studies are displayed here, and sample is around only or less than 200. And in another one, we have a high I square, though it has crossed 274 sample. The sample size is very, very limited. Now, what has happened because of the less sample size? It appears that the study power may be very low. Now, in such cases, what I should do is I should go for a trial sequential analysis. Now, we look at the p-value. It is very, very or highly significant, and the authors usually, without calculating sample size, what they will do is they will infer the data as my study findings are positive, therefore the conclusion will be directly drawn. In such cases, it is not advisable whenever the studies are 4 or less, or where the sample total required information size is less than 200. We cannot obtain the directly, we cannot make any conclusions. Now, TSA is the one software which is freely available, and every author is free to use it after the registration. So it is very, very helpful to cross check. In such cases, in spite we have the p-value very, very high significant, we will be unable to make any or draw any conclusions. Now, other issues also are finding. So, because we have not got the sample size adequate, and we have results with the p-value significant, now we have insufficient sample number, the conclusion usually, for example, this paper, association between the intraoperative ETCO2 and postoperative nausea vomiting. So the conclusion is made based on the p-value of the paper. But the authors will write that there is a strong independent association between the intraoperative ETCO2 and postop nausea vomiting. But however, what is wrong in this paper? Then TSC RIS, if you check sample size, it is not achieved, and I square value is very high. It was 72%, and meta regression has not been performed. So, because of these 3 reasons, Now, the truth is actually there is a insufficient evidence. However, the conclusion will be written as a strong independent association because of the ETCO2 value for the post-operative incidence. This is wrong. So this we call as overstating the conclusion. So authors require to change their conclusion that there is a insufficient evidence exists and nowhere the conclusion can be made. Sometimes we get unit analysis problems in the paper where you have 3-4 groups. For example, one study I have shown here, you have got 4 groups, and with each sample, each patient number is 15 for ABC group. One control group will be there. Now, what authors will do, we have 3 groups of study groups and 1 control group. Now, each time, now the author will try to put their control group into the other side and the study group in a different. For example, you can see here the events are different for ABC groups. However, for the D group, he has kept all the incidences for a single group. However, he has repeated. Now, can you look at the total number of subjects? So this is the subtotal. It represents the total number of population. Now, if you look at the numbers, it has become equal at both sides. Actually, it is the same patient here for all these 3 groups. So total number should have been changed. It is actually 49 out of 77, the incidence reporting, instead of 71 by 107 reporting. So this type of errors are very common when the different groups are available for a individual paper. This actually, this method will overestimate the incidences. Therefore, the p-value will come highly significant, and therefore the conclusion cannot be made. Now, one other aspect I wanted to address is like I say, comparison methods, the reasoning of the paper. Now, so for example, one of the paper is comparing. You think you are doing a study on fiber optic intubation using sedation, using midazolam and dexmedetomidine. Now, what has happened? The authors will conclude that DMD is better than midazolam. Now, if you look at the literature available in the database, there are multiple literatures available. For example, there were some authors have compared midazolam to fentanyl, some have compared midazolam to lignocaine, some similarly to dexamethasone to sufentanil or ketamine. So several permutation and combinations are available in the literature. Now, what the author trying to do is only one set of comparison among the several available papers for the same set procedure. Now, what we are going to get or obtain from this type of study? We will make conclusion either midazolam is better or DMD is better. However, we are having no knowledge about the other. In such cases, it is ideal to perform a network meta-analysis rather than doing a meta-analysis. Now, network meta-analysis will tell whether it will also tell midazolam versus dexmedetomidine is better, or whether it is midazolam versus remifentanil better, or for example, midazolam versus sufentanil better. See, there are no studies which are comparing midazolam versus sufentanil. However, by doing or conducting network meta-analysis, we will be able to find out whether midazolam is superior to sufentanil. So such type of comparisons sometimes can go meaningless. So identifying one drug and one comparison among many is unlikely to yield a good research for in the meta-analysis. So this type of errors are sometimes common. However, it can only add to the number of studies or number of meta-analysis increase. That's all. Otherwise, a network meta-analysis always stands better. And I think these are the common errors I addressed during the conductance of meta-analysis. Thank you.
Thank you so much, Dr. Tantry. I think nice comprehensive of various concerns when we do meta-analysis. I'm sure the listeners would have grasped the importance. Now, this is equally important by doing a meta-analysis, but this is also important when you read a meta-analysis. So this type of information will make you understand even the quality of reporting for the meta-analysis, and hence you can make a meaningful conclusion. So today's session is open for any question, and I hand over to the organizers for further proceedings. If there are any questions, we are most welcome to listen to those questions and we'll try to clarify them.
Dr. Baljit, you can do it.
I think these were both these talks were very enlightening. Enlightening in the sense that we have been doing t-test and chi-squares and other things, but we never go into such in-depth study of this statistical analysis. Now, these days it is becoming more and more important that the statistical analysis is done in a very robust manner, and that's what lends credence to the study that you have sent for publication. And I think there are no better person that we could have for these, Rakesh Garg, for whatever he spoke on, and Dr. Tantry thereafter complimented what Dr. Rakesh Garg started with. So my congratulations to both the speakers, and I don't see any questions here. Chat box, are there any?